When somebody who's been diagnosed with early breast cancer comes to see the oncologist, they're inherently worried that they're going to need very tough toxic treatment, particularly chemotherapy. And if a patient has a low risk of cancer recurrence and surgery alone with or without radiotherapy has a chance of cure, we know that that patient can be reassured that they don't need chemotherapy. On the other hand, understanding that patients have a much higher risk of recurrence is really needed to understand why a whole sequence of therapies might be needed.
We often refer to high-risk early-stage breast cancer, but it's very difficult to really say what is high risk, what is low risk. That can be very individual, the perception. Whether a 5% recurrence risk is high or low, that comes down to the patient in front of you. You can say patient, same age, same comorbidities with a different cancer type, a different stage of breast cancer will have dramatically different pathways and treatments.
When we assess a patient with early breast cancer after her surgery, there are a number of factors that we look at in the tumor together with the patient to work out what their level of risk is. The first and most important thing is the anatomical stage of the cancer, and that relates to tumor size. Less than 2 centimeters is small, T1, T2, 2 to 5 centimeters is medium, T3, more than 5 centimeters is large. And then nodal stage, that tells us how many cancer cells have gone into the lymph nodes. N0 is none, 1 to 3 is N1, N2 is 4 or more. And each of these correlate in a very clear proportional way to level of risk of recurrence.
When we look at the biology, there's a number of factors we consider. Obviously, grading is an important factor, but also the receptors, estrogen receptor, progesterone receptor, and HER2 receptors. I often look at the proliferation rate, Ki67, because a cancer with a 5% proliferation rate has a very different behavior than a cancer with 50, 60, 70% proliferation rate.
We also now have in certain subtypes genomic platforms that give us much more individual specific analysis of the tumor and the genes that have gone wrong in the cancer, as well as also BRCA genes that we can look at in the patient that tell us about whether they're at high risk of another cancer occurring. So we integrate all of this biology information and pathology and staging together with what the patient is like in terms of their other comorbidities and their own individual wishes about what treatments they wish to take, and put all of that information together in a consultation after their surgery to determine a treatment plan that's right for them.
And then they'll start and make the next decision. If everything's going well, then you carry on. But if you have to make changes, then we change it, and we'll find a way of carrying on with that treatment.
We have had a number of new treatments and treatment options integrated in ER-positive disease, obviously the different endocrine treatment options, but also now combination endocrine therapy, for example, with CDK4/6 inhibitors. In HER2-positive breast cancer, we routinely now use in higher risk breast cancer patients dual HER2 blockade, but also have the option of switching the HER2 targeted therapy after surgery in those patients who haven't got an optimal response.
Other targeted drugs have included those now looking at the BRCA gene mutation, which we know accounts for about 3 or 4% of breast cancer that runs in families. And the vast majority are triple negative, a small proportion, 15%, are hormone positive. And the Olympia trial showed that the addition of the PARP inhibitor olaparib for a year after conventional treatment compared to not further significantly reduced the risk of cancer coming back. And that has now been introduced as a standard of care in many patients for that small group with that key mutation.
And in triple negative breast cancer, it's probably the subtype where we have made most of the treatment changes in the last few years. We have changed the preoperative chemotherapy strategy. We've been routinely incorporating carboplatin as a very effective chemotherapy drug, which substantially increases response, but also decreases recurrence risk. We are now routinely offering immune therapy to patients with stage 2 or stage 3 triple negative breast cancer.
If we think about HER2 positive breast cancer, there we have targeted antibodies, trastuzumab and pertuzumab, both of which now integrated with chemotherapy before surgery give nearly a 60 to 70% chance of a complete pathological response. And that's really driven high cure rates in that subtype of breast cancer. Again, if there's residual disease after the chemo by the time you get to surgery, there are other drugs you can give after that called TDM1.
Breast cancer remains the most common cancer in women. Despite all the progress we have made, it is still a significant contributor to mortality in women, although we have increased the cure rates substantially over the last 20 years.
In terms of understanding where our research needs to continue to progress, it's really saying for those patients that despite the standard of care, they still have an appreciable risk of recurrence. And understanding the biology of why those cancer cells are resistant to those treatments and what drives that risk of recurrence is still something we need to continue to work on.
Please join us for the next episode when oncologists discuss new and emerging therapies for early breast cancer that are reshaping standard of care for high-risk cancer across all subtypes.